Hi everyone. Thank you for joining us today. My name is Annabelle, and I'm the Business and Support Services Manager at SI and along with Jill, are joining you today to help moderate this session. Welcome to this webinar on localized scleroderma in children, which is also known as Morphoea. We are very pleased today to be joined by members of the Manchester Children's Hospital Rheumatology team, who will be talking to us today about this topic and then afterwards answering any questions that you might have. So if you do have any questions, then you will see a Q&A function at the bottom of your screen. So please do type any comments in there and we'll get to them at the end. But please do note that we will be unable to answer any questions that might be very personally related to your situation, and we do advise you to consult your own medical team about these. So let me introduce the team that we have with us today. So Dr. Hannah Lithgow is a paediatric rheumatology consultant at the Royal Manchester Children's Hospital with an interest in connective tissue diseases and in particular scleroderma and lupus. And Jen Nesbitt is a highly specialised occupational therapist working with the rheumatology team at the Royal Manchester Children's Hospital. And she's been qualified since 2011 from the University of Salford and has since worked in the rheumatology team for 9 years. And joining us today is also Lucy King, who is a clinical nurse specialist who works with the team, with the both of them. So thank you, everyone. And please, if you would take it away and share your screen.
Thank you so much for that introduction, Annabelle, and thank you for inviting us to talk today. So hopefully I'll just manage the technology. Is that all showing okay for everybody?
Yes.
Fabulous. So we've just got a short presentation today, which we'll share with you. I'm going to give a bit of an overview about localised scleroderma or Morphoea, and then we'll hear from Jen and Lucy as well. So juvenile localised scleroderma is often also called Morphoea, and they are the same thing. So those terms are used interchangeably. So it's really important that we recognise we're talking about the same condition when we use those terms. It's not systemic sclerosis, so sometimes this terminology can be confusing. Both conditions might just be called scleroderma, but systemic sclerosis is a very different condition, which more frequently has internal organ involvement, which is very rare in Morphoea or juvenile localised scleroderma. We know that it's an autoimmune condition, so that means that the immune system, which is designed to protect the body against infections, causes problems, and in this case causes inflammation in the skin and the soft tissues underneath the skin as well. It is a rare condition, so probably in the UK about 50 to 100 young people are diagnosed with localised scleroderma every year, and if you had 1 million children, somewhere between 3 and 9 would be diagnosed with localised scleroderma every year. It is more common in girls, so about 2/3 of patients will be female, and there is a peak in sort of primary school age children, and then there's a further peak of new diagnoses in adulthood in the 40s as well. In terms of different types of localised scleroderma, it can be quite a varied condition. The most commonly used kind of classification criteria that we use as medics, as health professionals, are these Padua classification criteria. And the most common type that we see in children is something called linear scleroderma. So that means that it affects either an arm or a leg, or it might affect the face or the head. And when it affects the face or head, it's called craniofacial scleroderma sometimes. And there can be further names that we give to craniofacial scleroderma. So you might have heard the term en coup de sabre, which is sort of a sword strike lesion. It's a descriptive term, and it can affect the scalp or the face or the neck. And there's also a condition called hemifacial atrophy, also known as Parry-Romberg syndrome, which is where the entire of one side of the face is affected. And in that condition, you can get more severe disease with the deeper tissues being affected with that condition. The next most common type that we see in children is called circumscribed or plaque Morphoea. And these plaques can be quite superficial, so they might just affect the top layers of the skin. So you can see that diagram on the right of the screen. So it might just affect the top layers, the epidermis and the dermis, or it might be described as deep morphea or deep plaques, which affect the tissues a bit deeper as well to the skin. Generalized morphea is used when there's multiple plaques affecting different parts of the body. And pansclerotic morphea is is a rarer type of morphea where you get sort of significant, severe involvement of a limb and it goes all the way around the limb, but quite an unusual presentation. And then mixed morphea simply means that you've got multiple types. So, for example, you might have a linear scleroderma and some plaques or circumscribed morphea lesions as well. So, how do we diagnose localized scleroderma or morphea, and how do we investigate it? So, it can be diagnosed by a number of different healthcare professionals. So, often the first port of call is your GP. It is a rare condition, so some doctors will be less familiar with the condition than others, and they may well refer you to other specialties. So that might be dermatology in the first instance, it might be general paediatrics, or it might be straight to paediatric rheumatology. Unfortunately, what we know is that there's often a delay in diagnosis for patients. So, in a recent international study that we did across 17 countries with over 200 patients, the average delay from having your first symptoms or first noticing the skin lesion to getting a diagnosis was 18 months. So, there's lots of work to be done in trying to raise awareness amongst healthcare professionals as well as the public as well to try and improve that time to diagnosis. Generally, it's a clinical diagnosis, so healthcare professionals that are familiar with the condition can usually make the diagnosis on the typical appearance of a lesion. Sometimes you might have a biopsy if the lesion is perhaps more unusual, and the biopsies are usually done to rule out other diagnoses rather than showing specific findings in scleroderma, and they're not very frequently used. Blood tests, again, so these aren't used to diagnose scleroderma. There's no particular findings on a blood test, but they might be done if your doctor's thinking about starting certain treatments, or they might be done. We know that patients with one autoimmune disease can be at higher risk of developing other autoimmune diseases. So it might be to look at antibodies that we might see, which might indicate that somebody's at higher risk of having other autoimmune conditions. Imaging is not always needed. So sometimes you might have imaging to look at the depth of the lesion. The doctor might be wondering about the tissues underneath, for example. If you've got a lesion on your head or your face or your scalp, then often we will do a scan of the brain just to make sure that there's no changes on the brain, which are rarely seen alongside morphea. We will often refer you to ophthalmology, so the eye doctors, because we know that some patients can get inflammation in their eyes, often without symptoms, which can be associated with scleroderma as well. What happens in the clinic? So when you come to one of our clinics, we will talk about your symptoms. So we'll want to know about your skin. We'll want to know if you're having any problems. Is it itchy? Is it sore? Is it getting bigger? Have you noticed any new lesions? We'll also want to talk about your general health because we know that you can sometimes have other problems associated with scleroderma, such as arthritis. We know it can affect your mood potentially, or you might be more fatigued. So we'll often ask more general questions as well as just asking about your skin. We'll then want to do an examination, and that examination will obviously involve the lesion of the skin, but it might involve other things as well. So often we might look at joints, or if you've got any other symptoms, then we would examine depending on what symptoms you've told us you've got. And one of the main things we're trying to understand in the clinic is how severe is the lesion, how severe is the scleroderma, and also how active is the lesion. So we're trying to work out if you've got active inflammation that's still going on, or are the changes that we're seeing due to old disease and there isn't any active inflammation. And there's various ways that we try and assess these. So we use things called physician-reported outcome measures. And one of the main tools that we use is this tool called the Localised Scleroderma Cutaneous Assessment Tool. And you might have seen your doctor doing that. And what that looks at is signs of activity. And the reason this is helpful is both that we can look at change over time, and also if you see a different doctor or a different clinician, they'll be able to look back and compare more objectively than somebody simply describing what they think, is it active or not active. And within that, there is a score for looking at active inflammation, which will count, have you got any new lesions or is it getting bigger? We often look at erythema or redness, particularly around the edge of the lesion, which can indicate that there's ongoing active disease. And we also look at the skin thickness, again, particularly at the edge of the lesion. And we'll also look at changes that we think are due to more old disease, maybe burnt out disease, and that can be colour changes, so changes in the pigmentation of the skin. It might include and looking at the sort of loss of tissue, both in the skin and in the deeper tissues as well. And then we also often complete these tools called a physician global assessment score, which we score from 0 to 100, which will be your doctor's opinion about how active this disease is at this time. We also increasingly are trying to include patient-reported outcome measures, and these are particularly important thinking about future studies and how we work out, if we do research studies, how can we work out that the treatment that we're using is helpful to patients and is making the disease better. We've recently done a big international study looking at a new tool, which is called a Localised Scleroderma Quality of Life Index, or LOSCI, which some of you may have been involved in. And this is trying to capture all the aspects of localised scleroderma that may impact on quality of life. So, of course, asking about skin, but also asking about other impact. How does it impact you at school? How do the medications impact you? And so on. Dermatologists might use this tool called a Children's Dermatology Life Quality Index, which is very much focused on skin. It's not specific to Morphoea or localised scleroderma. It's used across different skin conditions. In rheumatology, we often use this CHAP questionnaire. So if you're under a rheumatologist, you've probably completed one of these. And this is very much looking at function and how much your disease is impacting your day-to-day function, and can be helpful for our occupational therapists to help thinking about how we can improve that and measure that over time. Similar to how we do the doctor's global assessment, we also ask the patients to often do global assessment, and that might reflect your opinion of how active or severe your disease is at that time, but also how much pain you're getting from that, again rated from 0 to 100. And there are also outcome measures which are used less frequently. They're generally more used in research, called PROMIS measures, which are developed in America, and they can measure different things. So they might measure fatigue, or they might measure anxiety, or they might measure your mobility, for example, depending on what's being looked at. And these are tools that are designed to be able to compare across different rheumatic diseases rather than being specific to localised scleroderma or Morphoea. In terms of treatment, so when we treat Morphoea or localised scleroderma, our aim is to reduce the severity of the disease and to prevent further changes that might not be reversible to the skin or soft tissues. And you may, depending on your disease severity and where you're being looked after, you may have involvement from various different professionals. Here at Manchester, we obviously run a tertiary paediatric rheumatology service, so we often see patients with more severe or significant disease. You might have less severe disease and just be under a dermatologist and not need input from all these different teams. And we call this a multidisciplinary team approach. So it's going to involve doctors, and that might be dermatologists, it might be a GP, it might be a rheumatologist, it might also be, if you've got lesions on your face, for example, a maxillofacial team as well. We've got nurse specialists and allied health professionals, occupational therapy and physio, which we'll hear a bit more about later. There will usually be a pharmacist in the background, if you've not met them, who can provide advice about medications, side effects, and so on. Psychologists can be really helpful. Obviously, we know that this condition can have an emotional and a psychological impact on children and young people. And in some areas, we have access to a youth worker, for example, who's charity funded and can support the child and the family as well. In terms of the medical treatment, so this is going to depend on the type and the severity of your disease. For very mild disease, so if you've got a plaque that's fairly superficial, then often this can be managed with topical treatment. So this means treatments that are just applied to the skin rather than given by tablet or drip, for example. Most patients will benefit from emollients to moisturise the skin. We also use topical steroid creams, we use vitamin D creams, and we use topical tacrolimus creams as well. And these can be used alone for mild lesions, or they might be used alongside systemic treatment for those patients that are needing systemic treatment as well. So in terms of systemic treatments, we often use steroids, and this can be either as oral steroids, which are given as tablets or liquids, or they might be given by a drip. Methotrexate is the main treatment that is used initially often in localised scleroderma or morphea, and this can be given as tablets or injections, and it's given once a week. It's actually the only treatment that in localised scleroderma there's been a randomised controlled trial in children and young people. And a randomised controlled trial, or an RCT, is kind of our gold standard of evidence in medicine. So it's where patients are randomly allocated to treatment or placebo, and then you see which patients do better. So this is quite an old study, but it was done in about 2011, I think now, and there were 70 patients included, and they were young people aged between 6 and 17 who had to have active and severe scleroderma, localized scleroderma, to take part. And they were randomized in 2-1, so 2/3 of the patient received oral methotrexate and 1/3 of the patient received a placebo. And they ran the study over 12 months, and they also gave all patients oral steroids at the start. So patients had 3 months of a high dose of oral steroids followed by a 1-month weaning period. So as you might expect, as everybody received steroids, everybody had an initial response to treatment, but the patients in the methotrexate group responded better. And when they looked at 12 months, 2/3 of the patient who had received methotrexate were in remission, so they hadn't had a disease flare, compared to 1/3 in the placebo group. So showing that methotrexate is an effective treatment within localised scleroderma or morphea. There are other treatments that are often used, so they might include things like mycophenolate mofetil or abatacept or so on that your doctors might use. And these are based on not randomized controlled trials, but there's lots of experience with these treatments in many centres, and lots of what we call case series where clinicians have written up their experience showing that these have had a positive result for patients. And then surgery is not so much a treatment, and it's reserved for sort of improving cosmetic appearance or function, and it's rarely required. And when it is done, it's important to have your disease in remission first. So that might include, for example, if you've got a contracture in a limb, you might have some surgery to release that contracture to improve your function, for example. I'm now going to hand over to Jen, who's going to talk us through occupational therapy and physiotherapy management of scleroderma.
Hi, okay there. So yeah, my name's Jennifer. I work at the Children's Hospital alongside Dr. Lithgow. We're very lucky here. We've got a very good MDT team that has allied health professionals that are working within that team. So today I thought I'd just talk through what we generally do within our team here. Sorry, next slide, Hannah. So generally speaking, our aim is to improve range of movement, increase muscle strength, address a quality of life, make sure quality of life is good, regain independence, and engage that with meaningful activities. So when we first look, we've got occupational therapy. So there can be quite blurred lines between knowing what an occupational therapist does and what a physiotherapist does. So from an occupational therapy perspective, we're looking at your ability to perform daily tasks. So looking at safety and participation in the daily activities that we do. So generally what we're looking at is a breakdown of function of what we're doing in our day-to-day activities. So in our day-to-day activities, we'll be supporting with ensuring independence with washing or dressing and eating. With those activities, sometimes people might struggle with them a little bit. So we might look at alternative methods to do it in a different way initially, and then build up a graded approach to build that into their routine, that the independence is regained over time. We can also look at alternative resources that could be accessed to enable independence if they're not able to do them by themselves. We also look at transfers, so supporting that patients are able to get on and off vary in different surfaces. So it might be the basis of surfaces at home, so transfers off beds, toilets, of chairs, but also transferring that into the wider community as well. So it's not just how we function in our home, it's how we function in our community. So looking at schools and hobbies and clubs and things like that we do as well. We do quite a lot of liaison with schools as well, so we tend to send quite a formalised letter out to schools, just giving help and advice how to manage the condition in a school setting. What we're trying to do, our main aim is to just reduce the impact that this condition has on their education. So if we can proactively provide the support, that is our aim, to try and reduce something crops up and then it takes days for implementations to put in place. So we tend to put that out there, that this could be used if this happens, but we may not need it at the moment. And it just means that we're thinking a little bit ahead of the curve in case it is needed. So we can do support, we can do like handwriting assessments, we can build up handwriting tolerances, support with exams, so getting rest breaks or extra time in exams, looking at support of return into PE and grading and building that up as well. And one of the main things we do is looking at reasonable adjustments within a school setting. So generally speaking, we don't need EHCPs or anything like that. It should be able to be done within the school's normal reasonable adjustments. And the reason for that is because normally additional funding is not required for it. And it's adjustments that could be made quite easily by the schools. So those are little tiny adjustments. It might be like additional time to get between the classes. It might be movement breaks. It might be toilet breaks. It might be having lockers in school to be able to put bags in them and things like that. But it's having things in place to support them as they need it. Some people find it quite tricky to advocate for themselves in a school setting, and it's quite hard to say I need this, especially at high school when you've got different teachers, and you've got to maintain that across a lot of different subjects as well. So some people might use like a traffic light system to show where their level of need is and what sort of additional support that they need. So it's just finding ways to help them advocate for what can help them in that setting. Another main thing that we do is joint management, so looking at range of movement. So have we got full range of movement of the joint, or have we got any restrictions noted in the joint? So we would always look on building into full range of movement in your joints, and then from that point we would build into strengthening. So quite often we can see weakness presents in a joint that's been restricted. So we want to build that up to get back to the baseline of strength before. So we've got a manual test that we can say grip strength against normative ranges, and we can see if that is slightly reduced and build that up to get that back to where it should be. We also want to look at as well, because if we've got skin tightness, we may struggle a little bit with finger dexterity. A lot of the things that we do subconsciously in our day really relies on the finger dexterity. So thinking about like buttons and zips and shoelaces, they're very tricky things to do if your fingers are a little bit more restricted. So we can work on building and supporting that back up as well. Fatigue management is another area that we tend to really support with. So when your body's focusing on recovering and repairing, that can have a big impact on fatigue and the general ability to carry out the activities that you're doing in your day-to-day. So what we want to do is make sure that doesn't impact the activities that you do enjoy, and we want to try and support getting back to those activities. Quite often when we've been quite poorly, if we've been quite unwell and we come back and we're like, oh, things feel so much better, we often don't look at the next step, that things feel fine because they're functioning, but actually, are we back at those activities we did used to enjoy? Are we doing all those things that that make each individual who they are? and trying to make sure we're engaging with those things as well to support. So generally what we would do is graded supported return. So we always go down the principle of that you wouldn't run a marathon tomorrow without training. So it's the idea that we build things up gradually and slowly to avoid like a boom and bust pattern, and to get us back to doing the things that you enjoy as soon as possible, really. We also provide some support on your well-being, so looking at sleep. So sleep has a big impact on your day-to-day function, the way you concentrate, the pain you get throughout the day, and it's really important that we're getting good restorative sleep, that we're getting the growth and repair throughout the night, so we can provide like sleep hygiene support, looking at relaxation, how we can reduce the stresses and maintain them throughout our day, so it doesn't have as big of an impact on our body. A big thing that we do provide as well is support on body image, trying to look at one of the big things at the moment is social media and the negative impact of what we see in the social media. Quite often it's triggered and repeated. So if you look at one thing, it then may spiral onto another section and keep moving through there. So it's kind of looking at, does what I look at on social media make me feel good about myself, or does it give me a negative thought? And it's trying to change those principles that we're moving away from things that don't make you particularly feel good about yourself as well. And we've got signposting. We quite often signpost to like Macmillan beauty advisors and the charity Changing Faces. They're very good as well. And also signposting towards mental health support as well. We can also provide equipment. Realistically, what we want to do is avoid that, but if we do need that, we can provide equipment. Our aim is to try and get people back to doing things themselves. So if we're unable to do it by themselves, but a piece of equipment means that they can do it without relying on somebody else, that's where we would introduce that as well. Okay, and from a physiotherapy perspective, the aim that we're looking at is restoring normal movement and function. So mainly what we're looking at is supporting the movement that we do in our day-to-day lives. So looking at range of movements, making sure joints are moving, making sure any joints are that are getting tightness, are getting stretched, and trying to prevent any musculoskeletal damage there. We're also looking at, from a physio perspective, is building strength and stamina. So quite often when we've been out of activity for a long time, we can be quite muscle fatigued, and it's just a case of trying to build that back up in a way that's manageable for each individual person as well. Mobility. So what we're talking about mobility is supporting how we get from A to B. So walking tolerances. Generally, people may struggle a little bit more walking longer distance, so it's building that back up, looking at the general balance in your body, looking at your core stability, your flexibility, your balance, and your posture. So sometimes you might see a physio and think, "What? Hang on, why are they looking at that? This isn't an issue." But everything sort of connects and links up through there. So we kind of look at it in a whole body perspective of how we can support each individual. Again, with OTs, they also look at supporting a safe return to hobbies and into PE, and encouraging increased cardiovascular fitness and supporting good bone health by doing weight-bearing activities. And they can provide support both on land, but also at certain centres, they may also be able to provide hydrotherapy support as well as that. Okay, so the main sort of principle what we're looking at here is wanting to keep moving, so keep joints and muscles working, so increasing those activity levels. We may adapt tasks temporarily or long term to make the tasks easier to be able to get over the next line to reach our next goals. Kind of like thinking like a staircase, that we take each step at a time, and we may adapt to move things as we go along to make the tasks easier to get to our end goals. So it's all about pacing as well. So how can we adapt all the activities that we're doing and building in rest breaks to enable us to achieve where we want to be. And the main overall arching goal is independence. So supporting independence in school, supporting independence in play, and in hobbies as well. So occupational therapists and physios can provide support in lots of different ways. So here at our hospital, and a lot of this is mirrored in a lot of other specialist hospitals as well, is we can provide care as an inpatient. So when patients are in for treatment or diagnostic requirements, we would support their acute needs whilst they're here as an inpatient and support a safe discharge home. So making sure the environment is safe, you're safe and happy to do different elements of your day-to-day function once you're discharged home. Once you are discharged home as well, we can provide outpatient care. So we have an outpatient setting within the hospital. In that setting, we can provide one-to-one rehabilitation. We can do it in groups, or we can do it in multi-professional. So sometimes in our setting, what we would do is have a joint OT and physio initial assessment, just to try and reduce the amount you're repeating yourself, and trying to ensure that you're not having to get taken out of school as often and things like that. So as an outpatient, we move away from acute care needs and we look at long-term management. Quite often needs are switch between those settings. So it's looking at supporting back into long-term activity and fitness. Referrals can also be made into community settings. So that's your community occupational therapists and community physiotherapists. We tend to keep hold of most of our patients here, but as we see people from quite distance, we do refer them on if needed, if that makes it a little bit more practical to access the service as well. And generally speaking, what we tend to do, one good thing that's come after COVID is we've got a bit more flexibility in providing support. So we've got more access now that we can do face-to-face appointments, video appointments, and telephone appointments as well. So generally speaking, from an OT or a physio perspective, if we don't need to have a hands-on session and we're doing an education session, we can do that virtually, which means that it reduces that disruption of you coming into the hospital there. But it's just an awareness of what we do. So from a scleroderma perspective, we have limited referrals that come through to our service, but it's just having awareness of what we do, and that service is open to all our rheumatology patients. So if you feel like anyone needs those things, get in touch with your rheumatologist, and they can make sure referrals are put into support as well. Okay, that's me done there. So we've got Lucy next.
Thanks, Jen. So as Jen said, I'm Lucy. I'm a paediatric and adolescent rheumatology nurse specialist. I'm just going to run through the sort of support that we offer as nurses for patients with a localised scleroderma. So the role of us in a sort of nutshell, if you like, so we provide holistic care for patients and families with long-term rheumatological conditions, which include scleroderma, but for a whole variety of conditions that we see in the service, including conditions like arthritis and lupus as well. We're the primary point of liaison between patients and families and other members of the team. So if you're at home and you've got a question or a query, that comes through us first, and then we're always able to discuss it or pass it on with other members of the team as well. We do a lot of medication management and blood monitoring as well. That's primarily handled within our service. And then we're also providing social and wellbeing support for our patients and families as well. So one of the biggest services that we provide is our advice telephone line and our email inbox as well. So it's a first point of call for any of our patients under our service who have any queries relating to their diagnosis or any questions around that as a topic as well. No question too small, no question too silly. I can guarantee you that it's been asked by someone before, and we're here to sort that out. So it's a non-acute service, so it's not for urgent queries or emergencies, and we're here within the office Monday through Friday. It doesn't operate at weekends or on bank holidays. The email is really useful because it can be used for queries, but we also use it for patients to be able to send over photographs, which is particularly helpful if it's one of those things that maybe you think that your scleroderma patch has potentially changed. It's helpful for us to get those photos so we can get it assessed by other people. And the outcomes of our advice line can be a variety of options. It can mean that you get an expedited appointment, so your next appointment with your consultant or your doctor is potentially a bit sooner. We can issue some prescriptions for you as well. We've got a number of nurse prescribers within the team, so repeat prescription requests can be handled by us. And it might mean that we signpost you or refer you on to a more appropriate service for the question that you've presented with, that might be potentially like your GP or another member within the team. And then any urgent or out of hours queries still have to go through the appropriate channels. But we have a 24/7 consultant on call, so if any other doctor wants to liaise with our team, that is an option for them as well. So as I said before, we do a lot of medication management within our team. That's one of our sort of like primary responsibilities, if you like. So we can issue repeat prescriptions and sort out associated blood tests for them, whether that be routine monitoring or additional testing if required. Patients come to us with any sort of side effects that they're experiencing with medication, and we can discuss ways to minimize those side effects or put it forward to the consultant if we think a change of medication is necessary or required. We can do formulation changes, so a number of the medicines that we use are available in different forms, whether that be tablets or liquids or injectable form, and we can look at doing those changes if you feel that's something that would be helpful for you. And then we can provide tips and tricks around adherence, so that's your ability to take your medication as prescribed every week or every day, as it might be, whether that be through alarms or reward charts, things like that. We can provide all of that within our team as well. Storage and travel advice, we go through all of this at the point when we start you on these medicines, but sometimes people need a little reminder, and we can issue things like travel letters to help with travel insurance if you're applying for that, and also if you're traveling internationally, going through airports and things, just to make it nice and easy and seamless for you. And then we're also the people that manage home care if you get clinical home care deliveries for things like injectable methotrexate. So if you've got any concerns with that, we're the people who are sorting that out for you as well. And for all patients who start on a DMARD treatment, so something like methotrexate or mycophenolate or abatacept, everyone gets a session in our nurse clinic as well to chat through that medication and any concerns they might have it as well. So the other thing we provide is sort of ongoing social support, and this doesn't really have any real specific limit. It's just everything that comes with having your condition and any support that we can provide around it to make things as easy for you as possible. So this can be breaking down barriers to attending clinical appointments in hospital. So that might mean potentially, as Jen was speaking before, changing the way that appointment is facilitated. So whether that be a telephone appointment or a video appointment. We can look into transport support if transport is the biggest barrier to you attending, and if there's support in place for that, or if it's a specific clinic time that's the only time that's available for you. Obviously, we have to operate within limits of our service, but it's, again, no question too silly. We can always look at that for you if it's going to make your life easier. And then we can also look at specific preparation for patients who've got specific challenges. So for patients with SEND, if they need sort of like pre-clinic preparation, whether that be social stories or play preparation before coming into hospital, or for coping with things like procedures, those are all things that we can get put in place for you to make any sort of like admissions or clinic appointments as easy as possible. And that can also be extended support for additional patient groups that have got additional responsibilities or needs. So that might be children who are under the care of the local authority, or children who have caring responsibilities as well. We can provide some initial guidance and, again, some signposting on financial support available to you if that's becoming a barrier for you attending hospital. So that can include things like transport expenses, referring you on to Citizens Advice. We're really lucky in our hospital that we have Citizens Advice based within our hospital itself, which is great. You can provide that specific support about what might be available to you, and that can be a bit of a postcode lottery. It can be a bit different depending on where you're in the country, and so it's always worthwhile asking the question, because Citizens Advice are the best font of knowledge in terms of that. And then any sort of benefits, means tested or non-means tested as well, Citizens Advice is a great forum for that too. We can look at referring on to other agencies if the wider family is needing support at the time. So that might be a service like Early Help, which comes through your local authority. or even something as simple, if you like, as your health visitor or your school nurse, or things like community nursing services, particularly if you're having difficulty with injectable medications. They can provide a great arm of support as well. We also look at referring on patients for forms of psychosocial support as well. So we're really lucky within our hospital that we have an appointed Arthritis UK youth worker who supports our patients who have a diagnosis of scleroderma, which is fantastic. I'll talk a bit more about the sort of support they can offer a bit later. We can also signpost to local mental health resources if that would be helpful. And then we do work with other charity partners as well to provide the best sort of all-round holistic support we can. So another one of our big responsibilities is sort of disease education, which is providing you the knowledge and advice that you need about diagnosis and management and medication, everything that comes with it. So for all of our patients, we provide printed and digital resources about diagnosis and treatment, and those are always continually available. So if anything gets lost at any point, we can always supply replacements or direct you to the appropriate avenue for those. We provide disease education for everyone who's newly diagnosed with scleroderma under our service. So that's a sit-down session where we talk through any sort of like anxieties or questions people might have at that point of diagnosis as well. Particularly nice to have a bit of time to sit back and reflect maybe after you've had that initial diagnosis, because those questions never come out about that time. It's normally a little while down the line. So that's what we're there for, really. We can provide that education again at any point, and we particularly think about re-educating like teenagers or adolescents if they were diagnosed when they were very young, maybe didn't have much understanding of their condition, and then entering adolescence when they maybe want to know a bit more. We can provide those education sessions again. And not everyone who has linear scleroderma will need the care of an adult rheumatology service, but for those who do, we provide support in terms of like transition, moving on through to an adult service, and the differences that they might see making that move across to try and make that as seamless as possible. And then equally, you might not be moving to an adult service, but you might be moving between paediatric services if you move to a different part of the country. And we have a fantastic network, paediatric rheumatology nurse network across the country, where we can reach out to and establish in advance who's going to be taking over your care once you've made your move, if that's what you'll be doing. So as I said before, we rely heavily on support from external organisations as well as what we have within our team at the hospital here. So I've listed off a few of the organisations, some of which I think we've already mentioned. So obviously Scleroderma and Raynaud's UK has an excellent font of like information and leaflets, particularly the Scleroderma in Schools leaflet is really, really useful, and that their initial resources we hand out at point of diagnosis to everybody because they're an excellent resource. It's been written by a number of people that we've worked with previously. There's the Changing Faces charity, which is for anyone who has a visible difference. It's a bit deceptive. It's not just about facial differences, it's about skin differences in general. And they provide a variety of different tools and research and things like that, and they're an excellent organisation as well. Citizens Advice that I mentioned before for anything sort of like socially related or anything financial, particularly if you're in receipt of any means tested benefits, they can assess whether you're in receipt of everything that you're eligible for. We occasionally refer our patients to nominate patients for the Over the Wall camp, which takes any young person who's affected by what they call a health challenge, who's been on a form of treatment within the past 5 years, and they provide sort of weekends away at their site in Derbyshire, which we get great feedback for. And then finally, I know it's a deceptive name, Arthritis UK, but they do support patients who are under the care of a rheumatology service for an inflammatory rheumatology condition. So that includes scleroderma, but also includes our patients who have things like arthritis and Raynaud's as well. And it is a nationally provided service. Not every hospital has an appointed youth worker per se, but it is a nationally appointed service. So if you're under a paediatric rheumatology team anywhere in the country, you can contact them via this email and they can loop you into their events program that they have going on. They run both online and face-to-face events, and it can be a great way for young people to meet other young people going through similar things to them, and it's a fantastic resource. But yeah, that's what we provide within the nursing team here.
Thank you, everyone. I found that really informative, and I hope everyone else did too. So thank you very much. And we will now be moving on to any questions that anyone might have. So like I said before, please feel free to put them in the Q&A function at the bottom of the screen. I will just start with some of the ones that were sent in beforehand. Bear with me one moment. So my child's doctor said his scleroderma should clear up on its own in about 3 to 5 years. He has Occupational Sabra. I have heard that this type can be bad and may affect the bone. So is it possible that it will clear up without treatment, or do you think that treatment could be needed?
So I think that's a really good question, isn't it? And I think it comes back to what we were talking about when we assess a skin lesion in the clinic. So we know that sometimes, these lesions over time, they have this period of inflammation, and at that point it's helpful to have treatment. Or it may be that this is more of a burnt out lesion, and actually we don't think there's any active inflammation, and therefore there isn't going to be any benefit to treating that lesion. So it's really important to have that conversation with your doctor and to be seen in the clinic, because that's part of what they'll be looking at about whether they think there is a benefit to treatment for your child or not. And I think that's very much a clinical decision, and it is part of what is done within the clinic. But sometimes it may be that treatment is not required if we don't think that there's any ongoing inflammation and that treatment is not going to benefit your child at this stage.
Thank you. So the next question is, can localized scleroderma progress to systemic scleroderma?
I think the short answer to that is no. They're two different conditions, so very much different diagnoses. So although the terminology overlaps and we use the word scleroderma against both of them, they are distinct conditions. So we don't see children with localized scleroderma morphea progressing into systemic sclerosis. They are different diagnoses.
Thanks. So this one's a bit longer. So I've heard that methotrexate can be quite challenging to be on. My child is 14 and quite quiet, and she is about to go on it. I'm worried that she will not advocate for herself about the side effects and how she is feeling. Is there any way you would advise helping her make sure her opinion about her own treatment is heard by our family and by our doctors? I don't want her to suffer in silence.
Happy to step up and take this one. So yeah, it's a real challenge for young people, and it's a real worry. Families feeling like their child's going to suffer through something like that with methotrexate, and methotrexate is such a challenging medicine from that point of view. You can either have absolutely no side effects at all, or you can have a really rubbish time with it. I think the important thing that the young person knows is that there are other options to methotrexate if methotrexate does not work for them. It's not something that you need to continue. It's not a personal failure if it doesn't work for you. There's plenty of people out there of all ages who cannot tolerate methotrexate because of the side effects. And there's plenty of things that we can do to try and manage the side effects of methotrexate as well. It's always prescribed alongside folic acids that can significantly reduce the side effects of nausea associated with it. And within our service, we also prescribe anti-sickness medication as well. That can be really, really helpful. And it's something that you'll always be asked in clinic every time, how are you getting along with your medication? And if you're not getting along with it, it's not something that we're going to force you to take long term. But equally, in terms of self-advocacy, I think another really important tool that you can have is making sure that you've got or trying to make contact with other young people who are going through a similar thing. That sort of community around you of other young people who are taking similar types of medicines can be really, really helpful. And I've seen it with our young people that it's really, really improved their ability to advocate for themselves in terms of treatment, which is absolutely brilliant. So that email that I provided before, back to Arthritis UK, if you fancy meeting up with some other young people who are going through similar things, that's definitely an excellent place to start.
Just to add to what Lucy said, that's a very comprehensive answer that she's given. The other thing that I was excited to hear about this question is that we're actually just about to start a study at the University of Manchester with some colleagues, and that's very specifically looking at this issue around methotrexate, because we know, like Lucy says, lots of patients tolerate it fine and it works really well, but there are also patients that have a lot of side effects, and it can be quite miserable for some young people. And actually this study that we're in setup is looking at exploring patients' experience around taking methotrexate and then developing resources with young people to empower them, exactly what they're saying about feeling able to participate in decision making and having a say within clinic consultations. So it might be a study that's of interest to some patients that are linked with SRUK. So perhaps when it's open, we can share the details. And if anyone is wanting to take part, then that would be an option as well.
That sounds very exciting. Thanks. So what would be some of the considerations when moving from child into adult care that you would say to keep aware of?
Happy to chip in with this one as well. So this is something that we quite extensively look at, the process of transition, if you like, moving through from pediatrics to adults if that is needed. The main differences in adult care compared to pediatrics are the fact that your appointments are probably going to be less frequent, and the duration of those appointments are going to be shorter as well. And the focus of those appointments will be entirely about your specific condition, your scleroderma. It won't be about other health issues that you'll be directed to your GP to deal with those. And the other big difference is the fact that between pediatrics and adults is all communication will be directed towards yourself as the young person as opposed to your parents. And any discussion about your condition with your parents or your carers, you'll have to give explicit consent for that to be able to discuss without you as well. So those are the big sort of differences. But as much as it's a process that can seem really big and scary, particularly when you've been under a paediatric service for a really long time, you do try and make sure that it's as smooth as possible, and looking for an appropriate time to make that transition is really important as well. So moving to an adult service when you're slap bang in the middle of your GCSEs is probably a really bad idea, or when you're in between changing treatments as well. So it's also always a negotiated process, and there should always be a backstop appointment in paediatrics to make sure that that care has been fully taken over by adults as well.
Thank you. So someone else has asked, my son has Morphoea and I'm expecting a second child. Is there a high likely chance that they will also get Morphoea?
So I'm happy to take that. So essentially, it's really uncommon for siblings to get Morphoea or localised scleroderma. So it's not a directly heritable condition. So it's not directly passed from the parents to the child. We know that autoimmune diseases can cluster within a family, but it's very rare that it's reported where siblings both have Morphoea or localised scleroderma.
Thanks. So the next one is, I am struggling to get the school to understand my daughter's Morphoea. She gets self-conscious about it and prefers to cover herself up, and she really hates PE, especially because of this. Is there anything that you can recommend that I give them or talk to them about?
Yeah, I can take that one. So as Lucy mentioned earlier, on the Scleroderma UK website, there is the access to the booklets and the school support booklets there. They are brilliant and they're a really, really good resource. It's worth getting hold of one of those and passing that on to school. Also, within your local rheumatology team, you could also request that your team send a letter to the school to give advice and support of how you can support them and make reasonable adjustments to increase her confidence in a school setting so it doesn't impact her education. Specifically within PE and things like that, reasonable adjustments can be done that alter in the PE kit to wear clothes that makes them feel a little bit more comfortable. They are quick fix, easy solutions to ensure engagement. But then it's also linking in with psychology support as well, from a body image perspective to see how we can support from a long process as well on top of that.
Thank you. So we've just had a question come in specifically about a drip. If you're on a medication when you are a child, is it likely that you'll keep it as an adult, or is it more likely that things will change?
So that's a really, really good question, isn't it? How long will your child be on medication? And obviously that very much depends on different individuals and the disease course that you have. Often we carry on medicines for a number of years, and that will depend on your disease and how active it is at that time. But often we also try and stop treatments as well. So usually if your child's been well and the doctors and the team have felt that there is an ongoing active inflammation, then we will try and stop that medication after a few years. And then we always monitor patients kind of longer term as well. So even if we stop a treatment, we would would still want to see that child or young person in clinic for a number of years afterwards to try and recognise any early signs of flare. And often the period around the diagnosis is actually the most challenging, because once you've got a diagnosis, you're then under a team who know what your condition is, they know what to look for, you know what to look for, and actually it's much easier to recognise a flare earlier and to get treatment restarted if it's needed. But many young people do not need lifelong treatment. We would often try and stop that treatment.
Thanks. So there's just one more question before we end. So this is, my child has both Raynaud's and localized scleroderma. I know Raynaud's can be connected to other types of scleroderma, but is it connected to localized, do you think?
So I think that's a really good question, and a lot of research has been done looking at what features can be associated with Morphoea and localised scleroderma. I think it's a bit complicated by the fact that Raynaud's is not that uncommon in the general population. So obviously it might be that it's just a coincidence that you have Raynaud's. So in research that's been done, it is described that some patients with Morphoea or localised scleroderma have Raynaud's. And perhaps they are linked, but I think it's very difficult to know. I don't think we know that clearly, because obviously Raynaud's is just common in that general population as well.
Thank you. So that's all the questions that we have, and all the time we have for today is actually 1 o'clock. So thank you to our speakers, and thank you to everyone for attending today. So if you'd like to sign up to upcoming webinars, then please do keep an eye on our website and social media pages. And to watch previous ones, please do visit our YouTube page. As just a note, we do actually have a parents and carers support group. And so if you would like to join, then please do get in touch at info@sruk.co.uk. And the next meeting is actually on the 11th of August. And for any more information on scleroderma and Raynaud's, or the support services we offer, then please do visit our website. So thank you, everyone, and I hope you have a nice rest of your day.
Thank you for inviting us.
Thanks, everyone. Goodbye.